Hello and welcome to the next lecture, which is Current and Emerging Role of Genomics. My name is John Feller. I'm the Chief Medical Officer for Halo Diagnostics. In terms of disclosures, I've got patent pending with our team for laser focal therapy treatment, and then also work as a consultant for CLS biothermia. A little background on Halo Diagnostics. We're a nationwide outpatient precision diagnostics centers company. We do community-based research and development and are really interested in the nexus between advanced imaging, other biomarkers, and using artificial intelligence and machine learning algorithms based on a biomarker ensemble approach to the data. So I'm going to be talking about the emerging role of radiogenomics, specifically in the context of risk stratification for focal therapy. So at a high level, what we're interested in doing is finding what we call whack-a-mole patients, that if you treat with focal therapy, they tend to come up with either in-field marginal recurrences or out-of-field incidence foci of cancer over time in a way that makes it difficult to manage them with focal therapy. And some of these patients are probably better off entering whole gland therapy as their definitive therapy rather than entering focal therapy treatment plans. Now, the purpose of this talk is to answer the question of whether or not risk stratification for focal therapy can be done using radiogenomics. So can we prospectively identify responders to focal therapy for prostate cancer and distinguish them from non-responders using kind of an ensemble approach with biomarkers? We define responders as having a negative biopsy at the treatment site at 6 months following laser focal therapy, and that they do not develop either in-field or out-of-field clinically significant recurrences, so grade group 2 or above over time. This is a list of the biomarkers and a limited bit of clinical information that we use for studying risk stratification in focal therapy. So age, initial PSA density, the results of the multiparametric MRI, a urine exosome test called ExoDx, index lesion volume on the multiparametric MRI, the quantitative ADC, so both mean and minimum of the index lesion, whether or not the patient has had a systematic biopsy, the Gleason score, the results of tissue-based genomics, and then some liquid biopsy results, especially looking at circulating tumor cells and cell-free DNA, or circulating tumor DNA. If we look at index lesion Gleason score versus treatment efficacy, not surprisingly, the percentage of patients who are non-responders versus responders tends to go up with higher Gleason scores, especially with regard to the grade group 3 patients compared to the grade group 2 and grade group 1 patients. This is shown in a different way graphically here, but essentially the patients who have positive biopsies at the treatment site that are clinically significant and are considered non-responders, the ratio of those non-responders to responders tends to be higher in patients who have higher Gleason scores, especially the grade group 3 compared to grade group 2 and grade group 1. Moving over to tissue-based genomics as a biomarker. Initially, we looked at PTEN and ERG, but we've moved over to Decipher for biopsy, or the so-called Decipher score. This is somatic genetic testing that's done on the biopsy specimen. Usually we're doing this in the MR-targeted biopsy patients where the quality of the core is best, but we also use a research use only tool called GRID. The quality of the cores is important. We know that there is tumor heterogeneity on a genomic basis as well as a histologic basis. So having quality cores, this study looking at this issue with regard to tissue-based genomics noted that the target needs to be adequately hit to make sure we have representative tissue-based genomics in terms of the overall prognosis for the patient. This is looking at Decipher scores with tissue-based genomics and MR-targeted in-bore biopsies in almost 200 patients in a series for us. Not surprisingly, as the grade group goes up, the percentage of patients that have a high genomic risk, so a high Decipher score, also goes up. Here you can see that that's about 50% in the grade group 4s, going down to only about 5 to 10% of patients who have grade group 1 histology have high genomic risk based on the tissue-based genomics. But still important, Many of these are those MRI visible Gleason 3+3s that probably are a subset that have a different natural history than the patients who are grade group 1, do not have high tissue-based genomic risk, and are not MRI visible. So this is a cohort we're very interested in following over time. If we look at Decipher score versus treatment efficacy, not surprising that the mean Decipher score tends to be higher in the non-responders versus the responders. As I mentioned, the GRID is a research use only tool that basically looks at the RNA expression levels for 1.4 million genomic markers. This is a cloud-based server type solution for data management. We're in the process of doing a paired cohort study looking at responders in light green versus non-responders in dark green using data from a paired cohort study. It's just a small, not statistically significant study at this point, but we have noticed using a heat map type of presentation that there are 20 genes that are upregulated in the responders that tend to be downregulated in the non-responders, and then another 20 genes here that we've discovered that tend to be downregulated in the responders and upregulated in non-responders. So nothing that's statistically significant yet, but an ongoing paired cohort study that's at least directional and very interesting. We looked at the urine liquid biopsy test, but I'd like to finish up with Biocept as a liquid biopsy test that we're using for risk stratification for focal therapy. This provides us with results with regard to circulating tumor cells and also cell-free DNA, or circulating tumor DNA is another term that's used for this. So this is a blood draw looking at circulating tumor cells and subcategorizes them as either being cytokeratin positive or cytokeratin negative, as well as the total number of circulating tumor cells. It also gives us an ability to look at cell-free DNA just from this blood draw. Not surprisingly, the percentage of patients in this database from Biocept that have circulating tumor cells is lower in the grade group 1 than it is in the grade group 2 and grade group 3 and above patients, where the percentage of patients with circulating tumor cells goes up as the grade group goes up or the Gleason score goes up. We've seen similar pattern here in our own cohort at Halo Diagnostics, with a relatively small percentage of the grade group 1 patients having circulating tumor cells, but still surprising. And this number obviously goes up as the Gleason score goes up. This is a nice presentation showing, if we look at the negative biopsy results at 6 months, here in blue, the number of circulating tumor cells initially compared with the number of circulating tumor cells initially in patients whose 6-month biopsy is positive. Then we see that there's a significant decrease in the number of circulating tumor cells that occurs at negative biopsy, where there's no circulating tumor cells on the 6-month biopsy. Notice that there are much fewer circulating tumor cells if the 6-month biopsy is negative compared to the number of circulating tumor cells if the 6-month biopsy is positive. And that pattern persists, even though it's very small numbers at this point, at the 12-month biopsy and 12-month MRI as well, in terms of the number of circulating tumor cells that are present. And this is in a cohort of about 90 patients that we have at this point. Put differently, we can look at this graphically. In the 87 patients in our focal therapy trial that we've looked at circulating tumor cells, 60% of them have circulating tumor cells, 40% of them do not initially. At 6 months, we've got follow-up circulating tumor cell evaluation in 35 patients. Notice that at the time of the 6-month biopsy after laser focal therapy, in 43% of the patients, the circulating tumor cells went from being detectable to being non-detectable. At 6-month biopsy, in 23% of these focal therapy patients, the circulating tumor cells decreased but still remained detectable. And then in 17%, actually at the time of the 6-month biopsy, the number of circulating tumor cells increased. So this is, very provocative information, and, some interesting questions here about maybe whether or not circulating tumor cells or cell-free, nucleic acids, whether DNA or RNA, could potentially be used to define biochemical recurrence after focal therapy or define minimal residual disease after laser focal therapy or other forms of focal therapy. It may become an integral part of focal therapy programs, regardless of the energy source. So, in summary, radiogenomics, multiparametric MRI followed by genomics and other biomarkers show promise for risk stratification for patients in focal therapy cohorts. A biomarker ensemble approach with multiple biomarkers to prostate cancer helps to mitigate the blind spots of these individual biomarker tests, as well as to mitigate the heterogeneity of prostate cancer as a disease. Research in radiogenomics in the setting of focal therapy for prostate cancer may help us to develop some novel combination therapies. For example, combining focal laser therapy with checkpoint inhibitors. In addition, it's obvious that the data gets pretty complex pretty quickly here, so multiple biomarker complex data sorts are obviously an artificial intelligence and machine learning opportunity, one of the things that we're aggressively pursuing at Halo Diagnostics. So with that, I'd like to really acknowledge our research team, especially Bernadette Greenwood, who's been doing some of this really exciting research in risk stratification with multiple biomarkers and radiogenomics. Thank you so much for your attention.